So good morning again. Thank you, Joseph. Thank you to the organizers for including me in the program. I'm not going to say thank you for scheduling me right after that fantastic talk by Sharon Wood. That was incredibly inspiring, and I don't think I can hope to match what Sharon has just shared with us. Let me say that I forgot the sport coat that I was going to wear this morning, so I would not have been a very good mountain climber. I would have left my gear behind. So that's not good. But it is great to be here. It's great to be amongst friends. It's great to see lots of familiar faces. Now, you know, some of the things that Sharon just talked about, I have to say, were incredibly similar, I think, to some of the things that we do. So she talked about being resourceful. She talked about being problem solvers. She talked about being creative, about the focus on teamwork and working closely with your team, about commitment. One of the quotes that I copied down, she said, "How slow can you move but still make progress?" And I must say there are many days in my IPC world and my new world of administration that I ask myself that. How slow can we move but still make progress? So it truly was incredibly inspiring. I think as I was listening to Sharon talk, some of the things that I deal with day to day, I began to wonder if we're really sweating the small stuff. But ultimately what we do is incredibly important, and I'm going to try to address some of those little things that we deal with on a daily basis that are going to sound familiar to you, that I think really do have an important impact on patient care. So I have no disclosures that are relevant to this particular presentation. And what I was asked to address, as Joseph has said, is I was asked to talk about complex issues in IPC, issues that get us into hot water, that the media gets interested in, that politicians get interested in, and how do we manage those sort of complex issues? And I thought I would tell you 3 stories to try to highlight how we manage these issues. Again, these are personal stories that I've worked through together with the team that I've worked with here in Alberta, and particularly in Edmonton. I'm going to talk about an ARO outbreak that we had a few years ago. I'm going to focus most of my time on the outbreak, the global outbreak of Mycobacterium chimera in CV surgery, because that's really what I was asked to address in particular this morning. I'm going to follow up at the end with a very brief reprocessing failure and how that was managed. And at the end of all this, what I'm hoping to do is leave you with some framework of how to address some of these complex issues that we confront. Now, we're used to crises. I have to say in IPC, we deal with this all the time. We have global outbreaks that we get ourselves in the middle of. Many of you are going to remember SARS from 2003. The headlines, 30 new cases of SARS in Ontario, H1N1 in 2009, and of course, more recently, the Ebola outbreak that we all prepared for, but fortunately, we saw no cases in Canada. And of course, you're all used to dealing with your own local IPC disasters. I picked a handful. Some of you are going to see yourselves probably in these headlines. This was in Ontario a number of years ago, 861 men who were exposed to some instruments that had not been adequately reprocessed. In Winnipeg, apparently, sometimes you don't clean your hospitals very well. In Ottawa, thousands of people exposed, again, the reprocessing failure. C. difficile in Quebec, C. difficile in British Columbia, and I will say everywhere in between. Sometimes in British Columbia, apparently you don't clean your surgical instruments, and we have the same challenges here in Alberta. Flesh on hospital tools, that was the headline a few years ago. And sometimes in Alberta, we even reuse syringes. In Scarborough, they had a dialysis challenge with 400 patients potentially exposed to bloodborne viruses a few years ago. In Halifax, apparently 64 women exposed potentially to instruments that hadn't been adequately reprocessed in labor and delivery. Montreal, similar sort of challenges affecting 175 patients having hip replacements, and an endoscopy snafu at the Peter Lougheed Hospital in Calgary that potentially exposed 35 patients. So you're all used to these things. You deal with them all the time. I'm sure some of those scenarios looked familiar. In IPC, we're used to being right in the middle of the storm and having to deal with emergent issues. And so as I thought about this and thought about a number of the challenges that we've had to deal with over the years, I thought about how do we do this? And eventually, after making many mistakes, you begin to realize that there is sort of a pattern to this, and you can actually replicate this pattern and try to do the same thing every time. So always, number one in infection prevention and control, confirm the diagnosis. So sometimes we get calls about all kinds of strange things that turn out not to be at all true. And I'm sure you've seen that happen. First thing you want to do, get the facts, get the details. Of course, you may not know everything at the outset, but you want to make sure you're not heading off down a path that is not at all necessary. So confirm the diagnosis. And of course, combined with that, if it's something that looks potentially bad, you want to think of some way of trying to control it or minimize it right from the outset. And then take a step back and think, okay, who can I phone? Do I have a friend that I can phone that can help me in this situation? And often there are multiple friends you should be phoning. Who's got the most information? Who knows the most about this particular situation, this clinical scenario that you've never seen before and you don't really know anything about? So you better start calling a group together of the experts in the area. Of course, there's usually IPC folks who can help you out, the clinical teams who are directly involved, the lab, public health. Depending on how your organization is structured, very often legal teams, communication teams, risk management might be involved as well. And very early on, it's important to decide who's the boss. In other words, who's going to lead this? Because you need to coordinate it. And we have found many times that we sometimes end up with multiple groups dealing with similar sorts of issues, heading off in slightly different directions, and you got to get it all coordinated, and it's very useful to identify who the lead is. Sometimes it's IPC, but often it's someone else from the clinical team that's really directly involved, and that's the individual that needs to pull the team together. And we have found that pulling the team together and having regular standing meetings can be very helpful. So at the beginning, it might be twice a day, 3 times a day, might be once a week, and again, it tends over time as things become a little more clear. Often you can meet less frequently as the issue is managed. And then you need to think who needs to know about this. And I must say, we've made many mistakes over many years. Inevitably, we leave somebody off the list. Who needs to know? Senior management, whoever that is in your hospital or your organization needs to know. Public health might need to know. Your Ministry of Health might need to know. And again, depending on how you're structured. So make a list. Think who needs to know about this situation. And again, we've made many mistakes, and inevitably we leave somebody off, and then we have to do some damage control. At the end of it all, you really want to think, what have we learned from all of this? What can we share with other people? Maybe what can we publish so that others can learn from our experience? And ultimately, how can we prevent this from happening again? So let me walk you through a few stories, and I'll start with this one very briefly, an ARO outbreak that we dealt with a number of years ago. So here's our Senior Medical Officer of Health, Dr. Preddy, and myself talking to the press about NDM1, New Delhi metallo-beta-lactamase 1. It was the day that, in fact, the Lancet paper was published that first described this new form of multi-drug resistance, and we were explaining to the press what this was all about and warning about multi-drug resistance and how it was inevitably going to become more common in our healthcare system. And then it happened. So we had a 62-year-old woman who had traveled to the Indian subcontinent for her son's wedding, and she had a fall while she was there, and she needed to have her femur plated, which she did. It got infected immediately, and as soon as she could, she came back to her local hospital in Edmonton, where the emergency note recorded that she had a huge dehisced wound that was pouring out this, thank you, Joseph, that was pouring out this ugly, foul-smelling stuff. And that stuff you won't be able to see very well, but it grew 3 multi-drug resistant organisms, an Acinetobacter baumannii, an E. coli, and a Klebsiella. So the long story short here is that she had multiply resistant gram-negative bacteria, including an NDM-producing Klebsiella, an NDM-producing E. coli, and an Acinetobacter that was multi-drug resistant by multiple mechanisms. And so she was admitted to hospital, and as soon as this was recognized, she was actually transferred to a different ward so that she could be isolated. And despite isolation, we managed to transmit Acinetobacter from the index patient across the hallway to another patient. That patient, as it happens, ended up being transferred to a different unit, and then we managed to transmit Acinetobacter to the patient in the room next door. That patient was convalescing from lung surgery, then developed pneumonia, respiratory failure, septic shock, was transferred immediately to the ICU and died within a few hours. So a horrendous story, all published in the reference that you can see here. And this was an example of secondary transmission of an organism that was brought back from the Indian subcontinent and ultimately transmitted to a patient down the road who ultimately had a terrible outcome from it. And of course, the media was all over this, and we were on the headlines for days, if not weeks. Fatality blamed on bacteria. Hospital hygiene failed. Poor hand washing linked to bacterial death of a patient. Poor hand washing likely led to the spread of a rare infection at our hospital. So let me just take a step aside for a moment and mention that you should never miss the opportunity to use a crisis for good things. And we use this crisis to focus on hand hygiene, and in fact we've used it for years to try to improve hand hygiene throughout the province of Alberta, and in fact to talk about routine practices, and in particular the cleaning of shared medical equipment, because clearly those were the failures that we had that had to have led to transmission of that multi-drug resistant Acinetobacter. So I don't want to dwell on it, but there was huge impact. It went on for a couple of months. There were 4 different hospital units potentially impacted, as well as our intensive care unit. There were 64 days in which one of the wards, at least one of the wards, had to be closed. 410 patients potentially exposed. A lot of multi-drug resistant screens that had to be followed up on. 6 patients ultimately involved, and of course including the 1 death that I mentioned, and I won't talk about it, but clearly there's huge reputational impact as the media publishes updates every day about how bad your hygiene is, how nobody in your hospital cleans their hands or cleans medical equipment. And again, this went on for a couple of months. So again, back to the basics. So we convened a very high-level team in the hospital to deal with this outbreak. I think if I remember correctly, we met twice a day at the beginning. Again, we had to deal with numerous potentially exposed patients, patients being transferred to other places. We had to deal with hospital wards that were closed to admissions, and so there were lots and lots of operational details to sort out, as well as dealing with the infection control side of things. The operational leadership in the hospital led that team, but again, we met regularly as we tried to deal with this, and it was really a major issue that went on at least for a couple of months. Who needed to know? We communicated broadly. There were lots of people who needed to know about it, and so we did certainly communicate very broadly. And ultimately, one of the things we learned is that we can improve our hand hygiene and our routine practices, and we continue to work on that to this day. So here's Leanne. I know Leanne's probably out there in the audience somewhere. Leanne and I facing the media as we tried to explain what had happened and what we were going to do to try to prevent this in the future. And what I would urge you is, if you are the one facing the media, it's really worth getting media training. I don't have the time to focus on all the aspects of media and media training, but I really would strongly encourage you, if you're the one who ever has to stand before the cameras or speak into the microphone, it's definitely worth getting the training. Media loves to focus on controversy, confusion, calamity, crisis, chaos. Those are the things they love. And if there's some angle related to sex, then they're just all over it. And they just love that tremendously. And I'll actually come back to that a little bit later. So when you do get media training, this is the short course, you're told to focus on a very few key messages that you keep coming back to. So you're really educating the public and the press. And think about what are those messages, typically 2 to 4. You want to be concise. Good if you can come up with a catchy short phrase. You want to make it conversational. You're teaching. And ultimately, you really want to maintain control over the interview. You want to look like you're in control. So let me move on to the second story that I'm going to tell you about, and this is the global outbreak of Mycobacterium chimera. And I'm going to subtitle it, "This is Infection Prevention and Control at its Best." And if you don't know this story, it's a real cliffhanger, so sit tight. Well, the reality is it's not so much a cliffhanger. As Dr. Dan Dijkema described this really as an outbreak in slow motion. And what I'm going to tell you about is truly an outbreak in slow motion. And it's about how this medical device that's manufactured in Germany became contaminated at the source of manufacture with Mycobacterium chimera, a very rare strain of mycobacteria that most of us had never heard of before, and how that strain of mycobacteria was spread around the world as these heater-cooler devices are used globally. So before I get to the actual outbreak, just a few basic things that you need to understand. For this audience, I don't think you need to be explained what airflow is like in the operating room. This is the way the engineers imagine the way it looks. I mean, it looks pretty clear. You know, there's a beautiful clean supply of air that comes from the top. It's HEPA filtered, directed in a laminar flow right down at the patient, lying on the OR table, so that the patient is actually getting this very clean air. And that's supposed to keep any of the microbes from around that might be in the room from coming in and entering the surgical wound. So that's the way it's supposed to look, and that's the way, again, the engineers imagine it. I'll come back to that in a few minutes. So what are heater coolers? For those of you who haven't been involved in this This is the particular brand of heater cooler that became a problem. It was called at the time Sorin 3T. It was bought by the LivaNova company, so it's known as the LivaNova or the Sorin 3T heater cooler device. And what it literally is just a big water reservoir that either heats or cools water. This is the front of the device, and you can see the big air intake on the front, and then the air is vented out, primarily out the back, but two small vents on the sides as well. This device sits in the corner of the operating room. It's not directly in contact with the patient, but it is in contact with the heart-lung machine. So the heart-lung machine circulates blood from the patient, oxygenates that blood, and as it's doing so, of course, the blood has to be heated so that it can be returned back, at least kept at body temperature, and returned back to the patient. And that's the role of the heater cooler. So it heats up the water to body temperature just to maintain blood as it's circulating and being oxygenated, keeping it at body temperature. Sometimes there's a cooling tank in there as well that the surgeons use to cool solution that circulates around the heart so that they keep the heart cool as they're working on it. So that's the heater cooler. The final little bit of background is, what are non-tuberculous mycobacteria? Well, you know about mycobacteria. It's divided, it's a huge family of organisms divided basically into two camps. There's the TB camp. So you know about Mycobacterium tuberculosis, airborne spread organism of public health importance, spreads from individual to individual. There are a few other organisms within that group, although Mycobacterium tuberculosis is by far the most common. And then there's a huge group of non-tuberculous mycobacteria. There are at least 170 of them on the list, with more being added from time to time. These are a group of organisms that are environmental organisms. They live in the soil, they live in water. They're of low virulence, but they can cause opportunistic infections in the right settings, and particularly, we've known for many years, they can cause chronic lung disease. Now, within that non-tuberculous mycobacteria group, there's the M. avium complex. There are 10 or 11 species within this group, and M. avium is the most common, M. intracellulare probably the second most common, and M. chimera is a rare one within this group, and it's very, very closely related to Mycobacterium intracellulare. In fact, it's just one base pair difference. But the importance of all this is that your laboratory typically is not going to do much work on these organisms. They're not going to be able to tell you that it's Mycobacterium chimera you're dealing with. They're going to report it out as Mycobacterium avium complex. That's the way it's reported out. If you ask them to, they can go back and do more work and tell you exactly which one it is, but in general, all you're going to know is that it's Mycobacterium avium complex. And again, we've known that these organisms can cause chronic lung disease for years. They can occasionally cause skin and soft tissue infections. So I used to show my kids pictures like this so they wouldn't go out and get themselves pierced. This infection is actually related to the piercing that's right up there on the tragus. And these organisms have been known to occasionally cause infections in breast implants, or in this case, in tissue expanders that were being used to prepare this woman for breast reconstructive surgery. There have been a number of nosocomial and iatrogenic infections related to this group of organisms. This was an outbreak involving 7 women from Switzerland who traveled to Latin America to get various cosmetic procedures, and the instruments were not reprocessed according to usual standards, and unfortunately they went back to Switzerland with terrible infections related to non-tuberculous mycobacteria. So with that basic background, let's get into the outbreak. So this is how the outbreak began. It was first described by a group from Zurich, Switzerland, who have done incredible work to work out all the details of exactly how this happened. That's mostly what I'm going to walk you through. So the first patient had an aortic and a mitral valve replacement in 2008, and then presented about 18 months later with a systemic illness of fever, weight loss, night sweats. The diagnosis was not at all clear, and there were a few options that they worked through, but eventually, about 18 months after that, the patient had to go back to the operating room for replacement of the aortic and mitral valve that over time had become destroyed. And here's the pathology. If you look at the slide on the right-hand side, it's a little hard to tell at this resolution, but those red dots that you see there, those are acid-fast bacilli on a ZN stain. So those are the red snappers that we call mycobacteria, and the valve was absolutely full of those mycobacteria that turned out to be Mycobacterium chimera. Around the same time that that patient was diagnosed, they diagnosed a second patient This particular patient had had an aortic valve and an aortic root replacement 2 years after the first patient, became ill about 18 months later, and ultimately ended up having repeat surgery around the same time as that first patient. This patient presented with a multi-system illness and in fact grew Mycobacterium chimera from multiple different sources. Now the important thing is those two patients, having had surgery 2 years apart, that's patients 1 and patient 2 in this molecular typing gel, and you can see that those two organisms were exactly the same. And that clearly was a red flag. How is it that two patients operated on 2 years apart had a rare infection with a microbe that most of us had never heard about, but those two microbes were exactly the same, and they were totally different than all the control strains that they were tested against. So that clearly that raised red flags for the IPC group in Zurich. They knew they had a problem. They did look for links between those two patients, didn't find any obvious links, and they put out in the literature that you should be on the watch out for this because they had no idea how common this could be at the time. But they then followed it up. They knew there was something strange going on, and they knew they needed to look back to see if they'd missed cases, and so they did look back. And in fact, they went back to all those Mycobacterium avium complex isolates that had followed cardiac surgery, and they did further workup on those isolates to see whether those isolates were actually Mycobacterium chimera. And long story short, what they found is that in addition to the 2 cases they knew about, they actually found 4 more cases. Typically, the incubation period was anywhere from about 1.5 to 3.5 years following surgery. Highest risk was for individuals who had either prosthetic valves or a prosthetic aortic graft put in. Patients presented with either endocarditis involving their new prosthetic valves or with a real systemic infection and multi-system involvement. And the group also they knew that there had to be a waterborne source somewhere for the Mycobacterium chimera. And so they began looking through the OR, through the intensive care unit, and through the ward for potential water sources where Mycobacterium chimera may be lurking. And what they found is they did find some Mycobacterium chimera in the heater-cooler unit, in the OR, as well as in the OR, in the air right around that heater-cooler unit. And so at this point, they knew that there was a problem. They now had 6 patients with this very rare infection, which they now were beginning to link to the heater-cooler unit. But of course, it wasn't at all clear just how common this was, and nor what we should do to prevent it. Now, around the same time, a group in Germany was also evaluating 5 patients who had exactly the same infection, Mycobacterium chimera. What they did is they actually went to the heater-cooler units. They could isolate the Mycobacterium chimera from used heater-cooler units. They went to brand new heater-cooler units that had never been used yet. They hadn't been shipped out, and they isolated the organism from those heater-cooler units as well. And they also isolated from the water supply in the manufacturing plant where those machines are made. So they found the source of Mycobacterium chimera. It looks like it's coming from the manufacturing plant in Germany where those heater-coolers are made. And this is now beginning to look very much like a point source outbreak, that the water supply in the plant is contaminated, the heater-cooler units are contaminated at the site of where they are manufactured, and then they're distributed globally. The real smoking gun then was, I think, in this particular study by the group in Switzerland again. And what they did is they did a few things. They put some settle plates out in the operating room, and they found that they could find Mycobacterium chimera out 5 meters out away from the heater-cooler unit. They did this laser particle study. So this is right over the chest of a patient that would be lying on the operating room table. And if that heater-cooler unit was turned on and faced towards, with the exhaust facing the operating room table, there were a tremendous number of particles in the air around the operating table. Now, if the machine was turned off, there were very few particles in the air, or if the exhaust was turned away from the patient, there were very few particles in the air. The next step were some smoke studies that I'm going to try to switch over to a movie to show you. And this is a movie I'm going to thank John Connolly, who I know is in the audience, and Tom Louie, as well as the group from Calgary. They sent me this movie. They went into the OR to simulate, and what they did is they provided a smoke source over in the corner here, right by the heater-cooler device that you can see. Oops, sorry, it's right here. I can't see myself. So here's the heater-cooler device, and there's the smoke, and you're going to see what happens to this smoke in the operating room. So now you're not seeing it. Well, okay, let's forget about it. Doesn't matter. It looks great here. Anybody want to come and join me? Sorry, it's not projecting. I'm sorry about that. It doesn't really matter. Let me just show you a still shot that's going to show you the same thing, although not quite as dramatically. Sorry, John, your movie is a great movie. So what it shows is that the smoke comes out of, it's propelled out the back with the exhaust from that heater cooler unit. It actually bounces off the ceiling in the OR and then joins that laminar airflow that's directed right down at the patient. And in fact, it's directed right down at the open chest of a patient who's lying on the operating table. Now, around the same time, this is fall 2016 now, the US begins to report cases. And so here we have 11 patients being identified in Pennsylvania and Iowa, and 5 isolates that were identified from heater cooler units. Importantly, all those 16 isolates from patients and from the heater cooler units on molecular typing, they're all exactly the same. And ultimately, it was shown that they were exactly the same as the outbreak strain that had been identified in Germany. So by then, it starts to hit the local, the news media. Bacteria on device causes infections in at least 12 patients in Pennsylvania. Consumer Reports puts out a notice, an essential heart surgery device poses a rare but deadly risk. So here we are, fall of 2016. What do we know? This particular brand of heater cooler unit manufactured prior to September 2014 might have been contaminated at the source of manufacture and then distributed globally. The manufacturer introduced a terminal disinfection step in August 2014. So devices produced after that time might not be contaminated, but we weren't completely sure about that at the time. And we did worry about machines from other manufacturers. We do a whole lot of open chest surgery. There are about 250,000 in the US every year, probably 25,000 in Canada. And we know we do about 3,200 a year in Alberta. We know that that particular brand of heater cooler has about 60 to 70% of the market share globally. In Alberta, at the time, we had 15 heater cooler units. 12 of them were that particular brand, all made prior to September 2014. And we had 3 that were made by a different manufacturer. And so at this point, the recommendations start flying from all kinds of national and international agencies, and we were bombarded with recommendations, and we had to figure out what were we going to do. Some of those recommendations, in fact, were conflicting. The CDC put out a notice that we should tell all patients that they may have been exposed. We should provide specific informed consent, and we should look back to see whether we had had any other cases. The FDA was focused more on the machinery, and they warned you that you should direct the exhaust from the heater cooler unit away from patients, and in fact, you should probably get rid of those old heater cooler units. The problem is there was nothing to replace them with. There was no way of getting new machines fast enough to actually replace those. And the FDA recommended that you not culture the devices, and that's a long discussion, but the FDA did not recommend culturing the devices. Health Canada, around the same time, put out a notice, again saying much the same thing, focus on making sure that you're adhering to cleaning and disinfection strategies as provided by the manufacturer. Look at the positioning of the heater cooler unit. Try and get them as far away from the patient as possible. Direct the exhaust away from the patient and try and get them out of the OR. In fact, try and get rid of the machines entirely if you can. Now, 2 months later, Health Canada convened a federal, provincial, territorial teleconference at which they told us that we should start culturing these devices on a monthly basis, and any machine that had been contaminated or was suspected to be contaminated should be removed from service. Now, on the same teleconference where Health Canada is telling us to culture the devices, our public health lab people are saying do not culture the heater cooler units. So lots of confusion on the same teleconference, and we're left trying to decide what exactly are we going to do. So locally, what we did is we pulled together a team. Heart surgery is performed in 3 places in Alberta, 3 different sites. So we pulled together the team. The team consisted mostly of the cardiac sciences operational leads, and in fact, they led this, but IPC provided considerable advice and direction, obviously. Our public health team was involved as well, and it was important to include our contract and procurement people in this particular investigation because we knew we were going to have to deal with the manufacturer. We were going to try to replace machines or get in loaner machines, and so we had to work with our contract and procurement teams. And again, we were thinking, who needs to know? Senior leadership, government, and we were communicating broadly and widely at this time. We worked closely with the manufacturer to make sure we were adhering to everything they wanted us to do. We looked closely at the placement of the machines, and of course we knew ultimately the only fix to this was ultimately going to be an engineering solution that didn't happen until the fall of 2017. So in some places, they wanted to get the heater cooler unit outside of the OR. They actually punched a hole in the wall of the OR, and this is now the heater cooler unit sitting in the hallway or in an anteroom outside of the OR. Calgary developed this rather elegant cabinet that they just put around the heater cooler unit to try to contain the exhaust, so that the exhaust would then flow out of the OR exhaust and not re-enter the OR. So here in Alberta, the next steps for us included notifying every physician in Alberta about this problem as they may start to see patients. We provided extra information for our infectious disease colleagues because we knew that they would be seeing the symptomatic patients. And then we distributed letters to 11,500 individuals who had had open heart surgery in Alberta, going back to the time when we first introduced these devices. And we prepared a call-in center because we knew that they would start to get calls. They may get calls from a spouse to say, you know, my husband or my wife had heart surgery 5 years ago and then died. Could they have died from this infection? And we got all kinds of calls like that, and you can anticipate it, and you need to be prepared for it. And of course, the media was all over this. Heart patient warns of risks of infection. Alberta heart patients warned of exposure risk to bacteria during surgery. And we sent out the letter to patients with a more detailed letter to physicians warning them what to watch for. The incubation period, anywhere from 3 months to 5 years, but typically around 18 months. Highest risk being any valves or tissue that is implanted in the patient. And the presentation typically is with some systemic features, fevers, night sweats, weight loss, might present with an infected heart valve, culture negative endocarditis, or might present with a disseminated widespread infection that may or may not include a surgical site infection, may include bone, kidneys, livers, and with all kinds of laboratory abnormalities. We also changed the informed consent for patients undergoing cardiac surgery. Because we'd not had a case, we informed patients that 1 in 1,000, or less than 1 in 1,000 was the risk that we expected. And at the same time, we began to look back to make sure that we hadn't missed any cases in Alberta, while also setting up a prospective surveillance program to make sure that we were watching for cases for here on in. So we found 20 patients in total that actually grew a mycobacterial species after having had cardiac surgery. This was a data link between our mycobacterial laboratory and our cardiac surgery laboratory. This was a tremendous amount of work, a number of people involved in this. And to make a very long story short, in the end, we sent these isolates to our national microlab in Winnipeg where they were all speciated, and we did not find any patient that had a Mycobacterium chimera infection following cardiac surgery in Alberta. So that was good news. So what's next? Well, we know the risk is out there. We sit back, we wait, and then we met this young man. This isn't actually him, but he looks sort of like this. A 22-year-old rancher from Alberta who was born with a bicuspid aortic valve that he had replaced with a new aortic valve in June of 2015. He presented 20 months later with night sweats. He had routine blood cultures as well as one set of mycobacterial blood cultures that were negative. And then a month later, while playing hockey, he started to develop chest pain. And he presented then a week later with now a week history of chest pain, 21 months out from having had his heart surgery. And what the arrow is showing here is a dissection of his aorta with a huge pseudoaneurysm that had formed, and he was rushed to the OR the next day. The surgeon commented that it did not look grossly infected, but he had a replacement of his aortic valve and a replacement of his aortic root, and the surgeon sent off specimens for culture, and 21 days later, lo and behold, Mycobacterium chimera was isolated. So we now have our first case. We brought our team back together. This is actually 6 months after our team had last met. We brought the team back together. Now, who needs to know? What are we going to do about this? Well, we have to change our informed consent because now we've had a case. The risk now in Alberta is somewhere between 1 in 100 to 1 in 1,000. And again, we looked at this all over again. What could we do to reduce risk further? And then we went out proactively to the media. We had told the media 6 months earlier that we'd never had a case in Alberta. Now we have to go back and tell them that's no longer true, and they were all over this, lots of headlines in the local and the national press. So let me just tell you about that patient. 1 year later, he remains on therapy. This is almost exactly a year since he was diagnosed. He's had some significant complications from his therapy, remains on therapy, will be on therapy for at least another year, and the plan beyond that at this point is not certain. And we've now had 3 more cases in Alberta. There was a very recent publication from the group in Zurich, Switzerland, that first identified this, and they estimate that there should be somewhere between 150 and 300 cases of M. chimera linked to cardiac surgery being identified every year. That's a modeling study, but that's their estimate. And thus far, there have only been about 120 cases reported globally. In Canada, there have only been 6 cases reported thus far. I spoke with Health Canada just a few weeks ago. There were 2 that were reported in Quebec right at the onset of all of this information, and we've now had the 4 in Alberta, and nobody else in Canada is reporting any cases. So this either means that we're really lucky, we're missing cases, or we're not reporting. And again, we sit back and we wait. The engineering fix for this was just introduced in the fall of 2017, and we know that the risk is going to extend out at least 5 years, and we may continue to see patients. And of course, particularly in the US, the lawsuits are just starting to emerge. Don't know how all that's going to unfold. And I must say that during these crises, one of the things that we really struggle with is how do we communicate risk? This is always a challenge. This is our former Chief Medical Officer of Health. He said, in any outbreak situation, our 2 biggest enemies are ignorance and fear of the facts. We certainly learned a lot about trying to communicate risk during Ebola. That's when this article was published. We're not very good at communicating risk, and we probably still have a whole lot to learn about communicating risk. But the message in this particular article was we should be absolutely clear about what we do know, and we should be equally clear about what we don't know and what we expect to learn over the next period of time. Let me just finish up with a final very brief story about a reprocessing event, and I'm sure that most of you in this room deal with occasional challenges in reprocessing. So this involved a fertility clinic in just this past December, about 6 months ago, and the reprocessing event involved vaginal ultrasound probes. The background is we found out on a Monday morning that the previous day, on the Sunday, there were 41 women in an infertility clinic who had had an ultrasound, a vaginal ultrasound performed as part of their fertility management. But we knew that based on the number of probes that they had and how much time it takes to reprocess probes, the absolute maximum number of women they could have seen that morning should have been 25. So clearly it doesn't add up. How did they examine 41 women when the maximum was 25? We went back over the previous week. 141 women over the previous week had had vaginal ultrasounds. We found that the records were inconsistent on 4 of those days, and in fact for 2 of the days the records were completely missing. And there were 3 service workers involved, and this was a long investigation, and I'm not going to go into all the details. Suffice it to say, this turned out to be a challenge related to one particular service worker. So we had some uncertainty or failure related to reprocessing. What would you do? And part of the reason I'm telling you about this is to highlight this article that was published just over 10 years ago, but we still use to guide our response. It's a terrific article. It was published in ITCHI in February 2007, if you want to go back and find it. A really useful article that walks you through step by step how to estimate the risk from a reprocessing failure, and that helps guide the next steps. And basically what they tell you, and the focus is primarily on the risk of bloodborne viruses, but you need to look at the prevalence of bloodborne virus or other infection in your population. You need to look at the risk of transmission by that particular route, vaginal ultrasound in this case. What is the likelihood that a contaminated device was used? So sometimes you have 1 device out of 5 that was not reprocessed. There's a 20% risk that a non-reprocessed device was used. You need to look at the efficacy of whatever reprocessing was done. Sometimes there's physical cleaning, but you know that the automated disinfector didn't work or whatever. And so there is some efficacy to that, and you can estimate what the efficacy might be. And then ultimately, if a device is only used once a month or once every 6 months, there's actually viral die-off over a period of time just through drying. So you can actually multiply all these numbers together and come up with a number. Now, in our particular situation, there were 141 women who had had ultrasounds over 7 days. We couldn't be sure whether the probes were reprocessed adequately or not. In this particular setting, we were worried about sexually transmitted infections and bloodborne viruses. But as it happens, this group is a group that is very highly screened. They're in an infertility program. They had all had STI screening and bloodborne virus screening over the previous year. Within that group, there was one woman known to have a chronic viral infection. She was on good therapy with the virus controlled. So in fact, ultimately, the risk in this particular population was really felt to be extraordinarily low and bordering on zero. So with that, would you disclose? Would you notify patients about a reprocessing failure and the risk? Well, let me say what you need to do, and this is highlighted in that article I referenced, you need to define your threshold in advance and decide at what level will you notify people. We've decided in Alberta that our threshold is 1 in a million. If the risk to a patient is greater than that, we will notify, typically. But let me say that, without going into all the details, in this particular scenario, there were lots of dynamics going on. Science-wise, risk-wise, in fact, we would not have recommended disclosure, but there were all kinds of other dynamics going on in the clinic, and there were decisions made at the time to notify 141 women. Now, that's not necessarily an easy thing to do. You got to be really organized. So we put together a script. 2 individuals phoned every one of those 141 women. We were prepared with questions and answers for women who were particularly anxious or angry or had questions that couldn't be immediately answered. The name was forwarded to me, and I phoned them and tried to answer the follow-up questions. You have to have a call-in center ready to deal with follow-up questions. And we did not recommend testing or follow-up for women, but for any woman who wanted it in this setting, we did offer them the requisitions so they could get baseline and follow-up testing. And this sort of event is absolutely going to hit the media, so you might as well go up proactively. So here are Janie and I facing the press, telling them that the risk is just about zero. And what we said is that there was the possibility that our usual reprocessing standards did not meet our standard of excellence, and that's why we were notifying women. That's exactly what we said. But there's a sex angle to this, and the media was all over it, and here's the headline. 141 women might have been exposed to a sexually transmitted infection. Makes a great headline. Fortunately, the follow-up headlines were a little bit more reasonable. Now, what they also said that Joffe was vague as I answered the questions. So asked why documentation gaps occurred only during that 1 week, Joffe was vague, but acknowledged that staff were busy. So what I didn't want to do is throw one of our service workers under the bus, because as I said, this actually related to the work of a single service worker as we did the full investigation. So I'm rapidly running out of time. I'm going to finish up by saying I've told you 3 stories and tried to highlight some of the complex issues that we deal with in IPC. I did want to focus in particular on the M Chimera and heater-cooler events that have unfolded over the last couple of years. And hopefully I've left you with kind of a basic framework. I'm sure you've all found this by trial and error, but maybe think about how you do it so that you can be a little more organized the next time, because there will certainly be a next time. And with that, I'll say thank you, and let's all make IPC great again.
Thank you.
So I really haven't left much time, I'm afraid.
Actually, you're quite good. We have about 10, 15 minutes, I think, right now for questions. So maybe what we'll do is, I know there's some questions from the webcast. Gwyneth, are there any questions from the webcast? Nothing yet? Okay, well, please let me know if there are any questions. Now, if there are any questions, can you actually state your name and where you're from, just so we get to know you a little bit?
Sure, Colette Ouellette from the Queensway Carleton Hospital in Ottawa. I have 2 questions here. One related to the mycobacteria, and one related to the last incident you described. So in the first case, you described the testing that was done with smoke testing and showing that the smoke would raise and mix with the air coming down over the patient if it was facing the patient. Was there testing done in the reverse? Because the recommendation was to have the exhaust facing away from the patient. Did you do the testing, smoke testing, to show that that did not provide an equivalent risk?
So if John's in the audience, he was a few minutes ago, he might be able to answer that better. So they actually did the smoke testing. So again, the laser particle studies that were done in Switzerland, what they showed is that if the exhaust was away from the patient, and really the idea is to try to direct the exhaust right into the OR exhaust so it's going right out of the room, so it's not re-entering the room. But John, do you want to speak at all to the smoke test that you did? Uh-oh, he's getting his exercise now. So I think really what the smoke test showed us is that although the engineers draw a really nice diagram of what airflow is supposed to be like in the ore. The reality is a little bit different.
Yeah, I can just comment briefly. I don't know if you can go back and show the video if the AV people can show, because the picture's worth 1,000 words while I'm speaking.
Unfortunately, it's not going to project, John.
Okay. They did yesterday project video. So anyway, the smoke testing showed that where the location of the heater, cooler unit was, and it actually had quite a high CFUs. It was something like 240 cubic feet per minute of air was being pushed out the fans in the 3 directions. And then what happened is when you put the smoke bomb testing by it, the smoke would just curl up, and it was much like a billiard table, and it would just roll upwards on an angle. It hit the roof and then bounced down, just like on a billiard table, directly over the operating room, as you mentioned, into the laminar flow. And when we put people around the operating room table, which would occur at the time of a surgical procedure, it actually formed a cone where the smoke bomb testing came right down. And because there were people surrounding it, you could see where the risk, if there were chimera droplets within that, it just hits the roof and then bounces down and then gets contained within a cone of the surgeons and others who are operating. So if they pull a valve out at the time and then put it in, they're basically having droplets of M. chimera that would be dropping on the valve or the prosthetic material.
Thanks, John. I think there was a second question.
There was I'm curious to know how you found out that 41 women had had procedures done on a Sunday. It seems a funny piece of data to be shared on a Monday.
So there's a background, as there always is. And in fact, for the same reason that we ended up disclosing, our threshold, as I said, is 1 in a million. The risk of a bloodborne virus or an STI having been spread in that clinic by that mechanism was way, 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 way less than 1 in a million. But the disclosure was provided again because of other dynamics that were happening. So the clinic was actually under a microscope at the time. It's a clinic that was in a public hospital that was transitioning out to a private facility. And it was under the microscope at the time, politically, media-wise, patient-wise. Everything we did was being scrutinized. And so I can assure you that the daily records were being monitored. And in fact, the women were being transitioned over to a different clinic right exactly at that time. So it was being, the long story, or the short answer to your question is the clinic was being monitored absolutely meticulously at that particular point in time.
Question here. A question here. There are emerging reports, despite the recommendations not to culture the reservoirs in the retrofitted Sorin heater cooler units, of mycobacteria still growing and they're retrofitted. Are we done with M. chimera yet?
I wish I knew, and the reality is we're not going to know for 5 years at least. For 5 years from the time it was recognized, for 5 years from the time that the engineering fix was introduced. But ultimately, I suspect what most of us are trying to do, those old machines now are, for the most part, reaching end of life anyways. We would love to replace them. The problem, I mean, there are multiple issues. Number one, you just can't get them. It's not just Edmonton or Calgary that's trying to replace their machines. It's everywhere that's using the machines across the world. Remember, that particular company has 60 to 70% of the market share. And of course, the other challenge is that the lawsuits are just starting to emerge. And what will be the long term for this particular company, I don't know, I can't predict. Are they going to be in the business long term? Which machine should you buy if you're going to buy a new machine today? I mean, ideally, we would like to replace them and ensure that the problem is gone, but that's going to take a fairly long period of time. I will say that Health Canada, during their discussions, made it sound like, well, you just call the company and they bring you a loaner machine and you send your machine back to Germany where it's nicely cleaned and then they send it back to you as good as new. Well, it wasn't quite that simple, and in fact, we never could get a loaner. I don't know if we ever actually did get a loaner machine because they were few and far between, and you can imagine that the Americans were probably shouting louder to get them than we were. Whether we should culture the machines or not, I think, and I know you have a strong research interest in this, John, and I think from a research standpoint it's absolutely worth doing, but whether we should be culturing these devices, the current recommendation from a clinical perspective is not to do it. The results are difficult to interpret, and they take a long time to come back, and it's well known that you can sample a machine monthly for years, and some months it's positive and some months it's negative, and how do you interpret that? And of course, you don't get the results for a period of time.
Other questions?
Hello, thank you for your talk. Neil Wigglesworth from St Thomas's Hospital in London, England. Actually, you've partly answered my question. It was about the retrofit. I was going to ask you if you, in your experience, the retrofit is working in a technical sense, because we're having problems actually getting it to even work. We're getting wetting of the filters and things.
So I don't know if I can answer your question directly, but the retrofit, so just backing up, it turns out that the problem with that particular brand of heater cooler, and as far as I know, there's never been an infection linked to any other brand of heater cooler, but that particular brand, again, has 60 to 70% of the market share. The problem is that there is a very, very small leak in the reservoir, down at the bottom in the reservoir, and that leak happens to be right in the exhaust stream from the machine. So there's a little bit of area there where Mycobacterium chimera can grow, can thrive. There's no way of getting rid of it, and it's right in the exhaust stream, so that it's exhausted out into the OR, which is leading to the problems that we're seeing. Now, do we know for sure that the retrofit works? So the retrofit involves a couple of elements. Number one, they've sealed up that leak so that it can't leak any longer. And number two, there's some kind of a scavenging device that is supposed to, if there is any leak, supposed to scavenge it so that it doesn't leak out into the exhaust stream. We have asked Health Canada, and I have not personally, but colleagues of mine have asked Health Canada about the evidence, and I can't speak to the UK, but we've asked Health Canada for the evidence that the retrofit actually works. And from what I understand, we've not been provided with any data to show that the retrofit does exactly what we hope it's doing. And as far as I understand, the Americans have not accepted the retrofit. The FDA has not approved it. Wait for a microphone. Put your hand up high.
Your presentation was fantastic, and thank you for that.
thank
I
you.
just actually have a request. I think the video with the smoke and showing the direction of the air would be very valuable to see, and I didn't know if there was a possibility of sharing it on the app.
So I have to ask John Connolly whether it's his video and Tom Louie and the group from Calgary. Yes? So we'll figure out a way to make it available as long as I have the permission of the people who created the video.
Fantastic.
I'm
thank
sorry
you.
it didn't project from here. It really is, the picture or the video definitely speaks thousands of words.
So I was wondering, with only 2 of the provinces reporting that particular infection, is there anything further being done to check as to why the other provinces haven't had any? Or
Well,
aren't
people in
reporting
this
any?
audience may be able to speak to that. No, I know as we were beginning to work through our challenges, we learned that British Columbia had never used the particular brand of heater cooler that we were using here in Alberta. So they probably were not at risk because they were using a totally different brand of heater cooler. But I suspect that other provinces are using the brand that has been implicated. Can't answer what the actions are. But I will say that so we've fairly recently diagnosed our 4th patient in Alberta. And this patient had been sick for quite a while, and clearly the infection was not recognized. It went on for many months unrecognized. And so it's certainly possible that across the country we are having these infections that aren't being recognized, or alternatively they're just not being reported to Health Canada. I don't know whether you in this audience know that you're supposed to be reporting to Health Canada. I don't know how clear they've made that. But back in the early days in the discussions, they provided us with a data collection tool that they did want us to provide should we diagnose an infection. So in Alberta, we have been telling them about our cases. I don't know what's happening in the other provinces and can't speak to that.
There's a question over there.
Just following up on the idea of using UV light to disinfect a room for patients or for Mycobacterium tuberculosis, could you not use UV disinfection to disinfect those machines the same way?
So a really good thought. Could we use UV to disinfect the machines? So I mean, with this particular device and the challenge that this device had, again, the problem is right at the bottom of the tank. It's really just a big water tank. There's a small leakage that's into an area that is not easy to access. So while UV light might be able to eradicate Mycobacterium chimera, it would have to be demonstrated, obviously. In the main reservoir tank, it wouldn't get, at least I don't think it would get to the area that's hidden and therefore is difficult to disinfect using the strategies that the company had told us for years we were supposed to be using. But it's a great thought. I guess the other question is, could we UV light the OR as a way of trying to eliminate it? Again, it wouldn't work for this particular device, but it's actually worth thinking about.
Hi, I'm Karen from Saskatoon, Saskatchewan. We are watching our lab results, and we would be reporting them, just so you know.
Thank you for sharing that with us.
I'm from Ontario, and we in Ottawa, and we are doing exactly what you're doing. We do not have any cases. We continue to culture our machines on a monthly basis. It is very labor intensive in the fact that we have to send it to Toronto, and it's a very costly way of doing this, but it's the only way. Only very few labs actually will test for it, so there's nothing in Ottawa that we could use. Answering to the UV, the McKays actually use a UV light in theirs, but they don't have the fan, and so a lot of people, it's the fan that's causing the problem. It's
Exactly.
not, so you,
It's the
so you
two
can
things.
have it
It's
in
the
the
leak
machine.
and the fan.
Yeah, so the McKays, we actually did culture our McKays, and we did found actually the same organism in them as well, so we did a disinfectant, but because they're not fanned out, it's not as a problem, so.
So I don't know if you want to answer this, but are you finding Mycobacterium chimera in your machines that you're culturing monthly?
Not so far. We actually did get a loaner sent. We sent a machine to Germany and got it back. It was supposed to be several weeks. It was like many months, but we did get several machines sent. It was very difficult, and you also have to remember that we have to continue to do cardiac surgery with machines being gone and stuff. So, but we always preface the thing with the patient, the risk of not having cardiac surgery was much greater than the chances of getting an infection.
Thank you. You've just raised a really important point that I'd meant to mention. One of the things we thought about early on is, should we suspend cardiac surgery? But the reality is the risk of suspending cardiac surgery, and I think they actually tried this at a hospital in Belgium, if I'm not mistaken. The risk of suspending cardiac surgery is far greater than the risk of acquiring Mycobacterium chimera from having the procedure done. And then the other point to mention is that you cannot perform open chest surgery without having the heater cooler device.
So I think we might have time for one more question. Last question.
I have the mic right now. I just wanted to clarify that in Ontario, there has been a case of M. chimera reported to Public Health, Health Canada. So there has been an Ontario case. It's a pediatric case, by the way.
Thank you for that. So I contacted Health Canada probably about 3 weeks ago, so I don't know if it's been in the last 3 weeks, but they seem to not remember that they've had that case reported.
So I think with that, we'll call the session to a
I'll stick
close.
around.
And Dr. Joffe will stick around to answer any questions you might have. So with that, please join me in thanking Dr. Joffe for this meeting.
Thank you, everyone.